We're going to start with the introduction. So once again, thank you everyone for joining. And the weather is actually getting nicer and warmer. It's getting more sunlight finally. And today we have indeed a great pleasure and a great honor to have Dr. David Messika-Zeitoun, who is a professor of medicine at the University of Ottawa and a cardiologist at the University of Ottawa Heart Institute, where he serves as the director of the Center for Valvular Heart Disease and leads the Valve program. He holds the prestigious Dr. T.G. Mezaner Endowed Team Chair in Valvular Heart Disease and one of the major cardiovascular researchers in Canada, supporting a comprehensive program focusing on improving detection, imaging, and treatment of valve disease. His research in Canada spans the full spectrum of valvular heart disease, from natural history and multimodality imaging to transcatheter therapies and population-based screening. He has led innovative initiatives such as mobile valve screening program and major international registry, and has contributed to the development of widely used clinical tools, including risk scores for tricuspid valve disease. With over 300 peer-reviewed publications and leadership roles within the Canadian Cardiovascular Society, being the chair of the Valvular Heart Disease Working Group. Dr. Messika-Zeitoun continues to shape both national and international practice in structural and valve cardiology. Please join me in welcoming Dr. David Messika-Zeitoun, and indeed it's an honor to have you joining us today. So please go ahead.
Thank you very much, Shiming, for the very kind introduction. So I've been asked to discuss about the detection and treatment of patients with valvular heart disease. So I apologize, but at your request, it's not very technical on echocardiography. So my disclosure, research grant from Edwards. So what I would like to discuss with you today is to present the unmet need that we have in valvular heart disease, which will be the rationale why we developed our screening program for valvular heart disease. So what are the unmet needs for valvular heart disease? We all know that the epidemiology has dramatically changed in the past 30, 40 years. I don't know if you can see my pointer. No. With a significant decrease of rheumatic valvular heart disease, marked increase of degenerative valvular heart disease, with also new emerging valvular heart disease that I will discuss. In terms of prevalence, it's clear that prevalence of valvular heart disease is increasing with age. It's estimated to be around 4% when in the population between 65 and 74 years old, and more than 10% when you reach 75. The most common valvular heart disease, as you know, are aortic stenosis and mitral regurgitation. And if you look at the population pyramids that we have in Canada as all in Western countries, what we can expect is that the population 65 years old or older will increase from 7 million to more than 12 million in the next 20 to 30 years. And it's important because, and I will show that, we will face a real tsunami of valvular heart disease. If you look at this epidemiology-based study done in UK, they screen at the family practice offices, individual coming for a visit that were 65 years or older for a valvular heart disease with a regular transthoracic echocardiography. And based on that study, what they found is that the prevalence of valvular heart disease is expected to double between 2015, when the study was done, and 2056. And what is also very important in that study is to show that half of them were undiagnosed. So we will face a double of numbers and also a double of numbers that are undiagnosed. And I mentioned that we have new emerging valvular heart disease. They can be also categorized in degenerative, but they have some specificity, and I will mention three of them. The calcific mitral valve disease. I took this slide for mimicking COVID. So you have the calcific mitral valve disease, the tricuspid regurgitation, and what we call the atrial functional mitral regurgitation. Calcific mitral valve disease is due to calcification of the mitral annulus, extending into the leaflets and causing mitral regurgitation, mitral stenosis, or more often a combination of the two. It's associated with cardiovascular risk factors. It's probably a mechanical component with a friction at the level of the annulus, but it's associated with cardiovascular risk factors. It's associated with an increased risk of stroke, myocardial infarction, and overall mortality. and it's very common. In that study that I done when I arrived in Ottawa, we looked all the patients that had an echo within a year, and we find that significant calcification of the mitral annulus, not calcific mitral valve disease, was very common, and that calcific mitral valve disease was observed in 0.5 of all the transthoracic echoes. One typical example here, the problem with calcific mitral valve disease is that surgery is complicated. Decalcification process is not easy. It's exposed to the risk of annular rupture. It's exposed to the risk of perivalvular leak. And we don't have, as for other valvular heart disease, easy, good transcatheter therapies options. Tricuspid regurgitation, it's also more and more, it's not I don't remember how it was called, undiagnosed or valvular heart disease is now attracting a lot of attention. And you can see that in that slide from Mayo Clinic, they have assessed the prevalence of tricuspid valve regurgitation in the population. As all the valvular heart disease, tricuspid regurgitation is increasing with age, the prevalence overall was very high, 0.55 of the total populations. There was a female predominance, but if you compare the prevalence of tricuspid regurgitation to that of aortic stenosis, they are very similar. And the third categories of valvular heart disease that we will see more and more are functional mitral regurgitation and functional tricuspid regurgitation. We know that we are doing classification based on it's a primary when the leaflet and or the cord are dysfunctioning or abnormal, and functional when there is no abnormality of the leaflet and no abnormality of the cord. And we have now this entity that has been described like a decade ago, which is atrial functional mitral regurgitations. So we have two types of functional mitral regurgitation. One is the ventricular one, which was the classical, when you have left ventricular enlargement, remodeling, tracting on the leaflets. And the second type, where the left ventricle is normal, but the mitral regurgitation is caused by the enlargement of the left atrium, enlargement of the annulus, causing this gap of coaptation. In terms of prevalence, if you want to memorize this rapidly, you have 1/3 of the patient have primary MR, 1/3 have atrial functional, and 1/3 have ventricular functional mitral regurgitation. And we have the same mechanism for functional tricuspid regurgitation. Both atrial functional mitral regurgitation and atrial functional mitral regurgitation are linked to atrial fibrillation. And we know that the prevalence of atrial fibrillation is booming, especially with the aging of the population. And it's also linked to heart failure preserved EF, which is also increasing markedly in the population. So clearly, we are facing a tsunami of valvular heart disease. And the lesson one is that valvular heart disease is the next epidemics. In terms of pathophysiology, especially for AS, we thought that it was a degenerative disease, just wear and tear, but we know more and more that the pathophysiology is much more complex, that all these valvular heart diseases are highly regulated, and that there is a mechanism that we need to understand better that lead to valvular heart disease. For AS, we know that we have this endothelial rupture, inflammation, infiltration of inflammatory cells, of oxidized lipids, cell differentiation, and creation of this bone-like matrix. Unfortunately, even if we understand that better, we have absolutely no medication to prevent AS progression. So the statins has been, we have 3 randomized control studies that have been all negative. Some have try to address that with different pathophysiological pathways, like medication for osteoporosis or vitamin K2, which is an in theory, anti-mineralization drug. All were negative. And so at the end, we are left with absolutely no medicated therapy for valvular heart disease, and the only treatment is a valve intervention. Could be, of course, surgery, or it could be transcatheter. And the problem is that, the good thing is that most of the valvular heart disease can be cured. This is partner 1B. You can see that in patients that were deemed inappropriate for any treatment, if you perform a TAVI, you decrease the mortality by 50%. So valvular heart disease are little if you left untreated, but in most case, we have options. And unfortunately, we have so far no medical therapy to treat valvular heart disease. But the good news is that we have less invasive option for now almost all type of valvular heart disease, besides some that are less amenable, like the MAC. In this study that we have done in France, we have collected all aortic valve replacements that were performed in France between 2007 and 2019. You can see that there is a marked increase of the number of interventions, mostly due to the increase of TAVI. And what is interesting to see is that it was not a replacement. The development of transcatheter therapy has enabled us to treat patients that were left untreated before. You can see, especially for people that were 80 to 84, they were left untreated, and more than 85, nobody was treating that by surgery. And so now we have option by transcatheter therapies. So they have completely changed the way we are approaching patients with valvular heart disease. If you want to manage someone appropriately with valvular heart disease, first you need to have the diagnosis of the valve, its severity. If the patient is not due for surgery or intervention right now, you need to carefully follow that patient, and you need to perform a timely intervention, what I call VNI-VT-VHD. Are we doing a good job in clinical practice? I would like to show you all this improvement that needs to be made. In that survey, they ask people more than 60 years, so almost 9,000 participants, what they were aware about valvular heart disease. If you can see here that valvular heart disease is very in the bottom. Everybody knows they're aware about cancer, of course, Alzheimer's, stroke, heart attack, diabetes, but nobody knows about valvular heart disease. And one of the consequences of that is, even in the medical population, physicians are not, there is not much awareness about valvular heart disease. And one of the signs is that the auscultation, both in male and female, when you go to see your family physician, is rarely done. In more than half of the visits, no auscultation is performed. And we know that auscultation, even if it's imperfect, we'll discuss that, it's the first line tool to suspect valvular heart disease. That survey was done in participants, so the general population. You have the same when you ask physician. In this survey done in Europe, more than 500 physicians, GP, cardiologists, and subspecialty cardiologists. We see again that in most of the case, there is an underuse of auscultation during the visit. And we know, we have seen the Oxval study, is that if you don't look for valvular heart disease, you will not find them. And half of the population, half of the valvular heart disease in Oxval were not diagnosed unless you do a systematic screening. So clearly, valvular heart disease are underdiagnosed. Not only that, they are undertreated. In this study from Mayo Clinic, so patient had an echo, were diagnosed with significant mitral regurgitation in that study. They have, it's important in the US, everybody had the echo, they had access to Mayo Care, there was no problem of insurance. And despite having a diagnosis of significant mitral regurgitation, only a small proportion of patients that had a class 1 indication for intervention, here 1/5, underwent a mitral valve intervention within a year. We look at that in that study from France. We collected all patients that were admitted with a code of mitral regurgitation. We had more than 1,000 patients admitted with mitral regurgitation. And you can see on the left that only 8%, 1 in 10, got a valve intervention within a year. And 92 were conservatively managed. What is interesting to see on the right side is that the epidemiology of patients with mitral regurgitation is completely different than what is reported from a very selected series from Mayo Clinic, Cleveland Clinic, for a mitral valve repair. Mean age of patient with mitral regurgitation was 77. More than half were female. 50% had more than 80 years. And you can see that even 12% when nonagenarians. And also, you can see that Charlson index was also very high. And what happened to this patient when they are conservatively managed in hospital? One-year mortality, I'm sorry, was very high, 14%. 1-year mortality, 1/3. A combination, sorry, of 1-year mortality of heart failure, and 2/3 were either dead or readmitted for any reason within a year. And was true for primary and was true for secondary MR. And we are not the only ones saying that. If you look at the STS database, the series was a little bit old, but still valid today. 50% presented with a history of heart failure, 40% had a reduced ejection fraction, and 24% had PH. We also look at that in the MatriCure registry that was published last year. It's an international registry of centers from France and Canada. We have in total 40 centers. St. Mike's is part of it. And we collected all mitral valve interventions that were done in 2019. We choose 2019 to be not to be impacted by COVID. For surgery, we collected 3,500 patients. I mean, age was 65, and 1/3 were female. And you can see again the advanced clinical presentation. 43 were presented in class 3-4. Heart failure, 1/3. Diuretics, almost half of them. Atrial fibrillation, 22% were sent for surgery with already atrial fibrillation. 1/3 has already reduced ejection fraction. And again, PH was quite common, 22% as moderate to severe. And so we are talking more and more about doing early intervention in patients that are symptomatic. If you look at MatriCure, only 4% of the population were referred for a surgery while having no class 1 or 2A trigger for surgery. It's true for mitral regurgitation, it's true for AS. This is a registry that we did in France, in Europe, I'm sorry, with 23 centers across 9 countries, and we find exactly the same findings, that many patients had frailty and comorbidities and referred very late in the course of the disease with severe symptoms or LV dysfunction. Tricuspid regurgitation, same issues. Here we collected all patients that were admitted with tricuspid regurgitation in France. Mean age was 75. Prior cardiac surgery was 22%. Half of the patient had also concomitant MR. Of course, ischemic or dilated cardiomyopathy was common, and half of the patient had heart failure. During 1 year, 20% of the population had an intervention, and only half of the intervention were related to the tricuspid valve. What is striking is that if you look at patients that were referred for a mitral valve intervention within a year, so all patients were coded with tricuspid regurgitation, and they were referred for a mitral valve intervention, meaning that they have both significant MR, significant TR, and you can see that the tricuspid valve intervention was neglected in 1/3 of the patient referred for mitral valve surgery. And outcome of this patient is quite poor. In hospital mortality, 5%. 1 year mortality was 18%. And then 1 year, 1/3 of the population were either dead or readmitted for heart failure, exactly like for mitral regurgitation. And was true for patients that had prior surgery or left-sided disease, or patient that had what we call isolated TR. And we have seen how prevalent is TR. We look at how many patients get a tricuspid valve surgery. At that time, we didn't have transcatheter options. What was striking is that in France, so the population is around 65 to 70 millions. Only 120 patients per year underwent a tricuspid valve surgery. And we can discuss that. In that study, we find again that operative mortality for tricuspid regurgitation was 10%. To understand a little bit more about this 10% mortality, we built another registry. We asked 12 colleagues from France to collect all the tricuspid intervention that were done in their centers between 2007 and 2017. What was good is to see on the first graph that the number of tricuspid valve intervention has markedly increased during these 10 years. However, it was mostly concomitant intervention done at the time of mitral valve surgery. And if you see in I'm sorry, I cannot have my pointer. On this, the bottom curve, the number of isolated tricuspid valve surgery in Brown remain very low and very constant over time. I mentioned in that the administrative database, we find the operative mortality was 10%. We find again that in that series, in-hospital mortality for isolated tricuspid valve surgery was 10%. So among the 5,000 something patients that we identified with tricuspid valve surgery, only 466, so less than 10% were isolated, and we find again the tricuspid valve mortality of 10%. You can see on the blue and orange in-hospital mortality rate of major complication were highly different according to etiology, with the highest being when you had a prior left side surgery before, around 15%. And for endocarditis, mortality was only 5%. But what was very interesting in that study, which led to the development of the TRI-score, was to demonstrate that when you adjust for the clinical presentation, etiology was not an independent determinant of outcome, meaning that the 10% of the high mortality associated with tricuspid valve surgery was not due to the fact that tricuspid valve surgery was complex to do. In fact, it's relatively simple for surgeon. It was due to the fact that patients were referred very late in the course of the disease. And so if you send a patient for a tricuspid valve surgery with ascites, he's going to die. And that's why the timing is key. It's known for everything in life, but more so for timing of intervention for patients with valvular heart disease. And I took this graph from its economic courses, what they call marginal gain. It's that how much you need to invest and how much you gain based on at what stage of disease or value you are. And you can see that if you develop for improving outcome of a procedure, you will spend a lot of money for gaining a very little bit. In contrast, if you work on timing, if you perform timing intervention, you will spend a relatively low amount of money and you will gain a lot. And that's the concept of marginal gain. And it's even more and more important as we have accumulating data showing that we should, at least in selected patients, proceed with intervention before the development of symptoms. There have been several randomized control studies in asymptomatic severe ES suggesting that instead of having watchful waiting, we should be proactive and proposing in selected patients an early intervention. It's true for AS, it's true for mitral regurgitation. It has been shown in that study that if you perform surgery before the development of class 1 or class 2A trigger for intervention, the outcome up to 10 years is much better. And so valvular heart disease are undertreated and patients are referred too late in the course of the disease. In addition to that, you have heterogeneity in the treatment of patients with valvular heart disease. Here we collected all patients that had mitral valve surgery in France over 2 years, again, administrative database. You can see that mortality is very different than what you see again in series from Cleveland and Mayo Clinic. Mortality at 1 year for degenerative was 13% and for secondary was 27%. And if you look on the bottom, only patient that had degenerative MR, you can see that the rate of repair overall was only 80% in the best subset. So patients that were less than 65 had a Charlson curve of 0. Overall, the rate of repair was only 84%. And there was wide disparity between male and female, with women having a significantly lower rate of intervention and mitral valve repair than a patient with than a man who got more repair and women more replacement. And of course, you have a decrease of the repair rate with age. And this concept was called by David Adams, one of the surgeons from New York, the lottery of material repair. In France, we are lucky that we have a very centralized healthcare system with mostly large centers. In the US, it's very heterogeneous. You have very big centers, again, New York, Mayo, Cleveland, but you have a lot of very small centers that are performing 20 or 30 material surgery per year. And based on where you get your surgery, mortality is different and repair rate is highly different as well. And again, for sex disparities, this study from Marianique Clavel from Quebec, it's interesting, showing that mortality of women with ES is significantly higher than the mortality of men. And one of the reasons may be that, it's on the bottom part of the slide, that the rate of women getting an intervention is lower than men. And we have seen that if you don't proceed with an intervention, the valve will not be fixed alone, and mortality is much higher. And we have also country-specific issues in this study from I think it was from Toronto. They compare rates of access to TAVI between Ontario and New York, and you can see that for the same population, adjusted for the same number of inhabitants, Ontario was doing much less TAVI than New York. What was interesting is that good thing for us is that we're not treating patients based on the socioeconomic status. Everybody was treated the same, regardless of their income. So there is clearly inequality in valvular heart disease treatment. So what we can do? The first thing is that we need to raise awareness regarding valvular heart disease. One way is to compare what is the impact of valvular heart disease to other diseases that people are aware of. In the study I mentioned regarding patient admitted with mitral regurgitation in France, we look at the mortality and compare that to the mortality of breast cancer. So for mitral regurgitation, we have exactly the same number of new cases with MR than breast cancer, and exactly the same number of deaths. So in terms of lethality, mitral regurgitation was visually similar to breast cancer. It's sometimes easier to convince policymakers when you talk about money. And we look also about the cost of the admission of patients with mitral regurgitation. And in 1 year, mitral regurgitation represented a cost between 350 and 550 million euros. So it's been around 400 to 600 million US dollars. So we have campaigns regarding Alzheimer, breast cancer, stroke, heart attack. There's very few or almost none with valvular heart disease. We try to change that now with organizations like Heart Valve Voice, which is an international organization, to raise awareness regarding valvular heart disease, mentioning that the symptoms are quite common: shortness of breath, dizziness, fatigue. And as Shiming mentioned, we have in 2022 created the working group, CCS working group on valvular heart disease in 2022, with the goal of raising awareness in the population and improving the care of Canadians with valvular heart disease. And one of the key actions of the working group, in partnership with CCS, has been to push in Ontario the government to declare the February 22nd as a heart valve disease day. There was a bill, I think it's 52, I don't remember about the numbers, but now we have a heart valve disease day in Ontario. And I mentioned the Rene Vidi-Vici. You can only treat the patient that you are diagnosing with valvular heart disease. And so the one key point is to detect patients with valvular heart disease and follow them carefully if you want to treat early. So I discuss auscultation. Of course, auscultation is key during the physical examination. It's fast, inexpensive, and cost-effective. What we need to understand is different to perform an auscultation when you have a patient in front of you in a visit than using auscultation as a screening tool in the population. And if you look at cardiac auscultation for detecting valvular heart disease in aux valve, so using auscultation as a screening tool in the population, the performance are not that great, even for a cardiologist with a sensitivity of 31%, specificity of 81. So auscultation may not be the best tool for performing screening at the population level. You may argue that we have now AI, and that with electronic stethoscope, you can have automatic interpretation of auscultation, which may be more sensitive and more specific. The literature is not that concordant. And that's why when we developed our screening program, we said that instead of using a surrogate for valvular heart disease, what we should do is have a real diagnosis of valvular heart disease. And for that, point of care echo now is an ideal tool for the detection of patients with valvular heart disease. And so I would like to discuss now the Heart Institute mobile screening program that we have developed when we started in 2023. So the rationale is what I've discussed, is that if you don't detect and screen patients with valvular heart disease, there is no way you can prevent or avoid that patients are presenting still very late in the course of the disease. And so the hypothesis is that if you go into the community and perform a POCUS, point of care echocardiogram, to screen for valvular heart disease, you will improve the detection of patient with valvular heart disease, and you will improve the care of patients with valvular heart disease. What we have added in our algorithm is an automatic referral of patients that were diagnosed with valvular heart disease. As you know, access to family physician in Canada is quite complex. Access to cardiologist is also complex. And so we didn't want patients diagnosed with valvular heart disease left alone. And so each patient that are diagnosed with valvular heart disease is automatically referred to our clinic here. So the study design, we went to do screen into the community in the region surrounding the Heart Institute, with a focus of providing this screening to underserved community. We sent one nurse, one sonographer into these different places, and I will show you some example, and one cardiologist. It's basically me, being at the Heart Institute in backup to support the team when they have issues. We have decided to screen only participants more than 65 years old of age. The reason is that you have seen at the beginning, the prevalence of valvular heart disease is markedly increasing with age, and there was no point screening young patients. But we can argue that the 65 years old threshold is debatable. We want to screen patients that never had an echocardiogram, at least in the past 3 years, and didn't have a reason for having an echocardiogram as well. So we include patients that have non-valvular heart disease, that had coronary artery disease, arrhythmia, stroke, or PAD in the past 5 years. How we do that in practically? So the nurse is first seeing the participant and review for eligibility criteria. We are doing registration into our EMR, so everything is collected. And the nurse is screening after that for cardiovascular risk factors. When we decided to do the program, I'm more a valve guy. So the aim was to detect valvular heart disease and screen for that. But we were discussing with the team and said, since we are here, why not doing a much bigger cardiovascular screening? And so at the beginning, we decided to add screening for cardiovascular risk factors. We screen, of course, for smoking. We take the blood pressure. And for diabetes and dyslipidemia, we do a point of care blood. So we looking for HbA1c and LDL cholesterol. And of course, we look for weight. After that, the patient is sent to the sonographer, and we use the POCUS Luminify to do the point of care echo. And when the point of care echo is done, the sonographer is providing the nurse with a preliminary report. The nurse is discussing the result for both cardiovascular risk factors and the POCUS with the patient. And we review all of the notes and the POCUS at the end of each visit, and we confirm or change recommendation that will be provided to the patient based on the final review of the echo. The issue is that we bring everything to each location. So we bring, of course, our laptop. We need Wi-Fi connection or hotspot. If you want to do an echo, you need to have a table. You need to have the blood testing machine, all the education, all the assessment tool that you need to bring with you. And let's skip this one. And just so this the Affinion machine that we use for HbA1c and for the LDL. And at the end of each visit, we have a final recommendation, which is in the MR and also given to the patients. Some of the settings. So here you see the nurse with the computer logged into Epic. She's taking here's the blood pressure. You can see on the right one of our sonographers doing the point of care echocardiogram. So we have very different settings. In this slide, you see again on the chair, we didn't have space where to put that. The machine used for the point of care blood. The sonographer is on the back holding the preliminary report to the nurse. And you have to be very flexible. That's kind of pictures that we took from different settings. You can see that sometimes we are doing the echocardiography in the library with a bench that we transport for each visit in between the closets. For now, we do everything with our own cars, and you can see one example of the back of one of our nurses' cars with the boxes with everything inside. And what you see, the gray boxes on top of the big boxes are the Affinion machine that we bring to each clinic. And we have developed this algorithm. So based at the end of the visit, if a patient is diagnosed with valvular heart disease, is automatically referred to us for a regular transthoracic echo and a visit with one of our cardiologists. But we do a focus. So sometimes you find valvular heart disease, sometimes you find something else. If we find something else urgent, we send the patient for emerge. It happens, I think 6 weeks ago. We find a patient with an ascending aorta of 91 millimeter. So participant was referred immediately to emerge and had surgery the following day. If it's semi-urgent, we have an agreement at the Heart Institute with our rapid access clinic that everybody had semi-urgent findings, so like LV dysfunction and regional wall motion abnormality, they are referred to the rapid access clinic. And when it's a non-urgent echo findings, for example, moderate enlargement of the ascending aorta, or if they are uncontrolled and diagnosed cardiovascular risk factors, we refer the patient for now back to the family physician. And if they don't have one, to a walk-in clinic. And we provide list of walk-in clinic in the area. We have visited more than 100 places now. Some of the spots that you can see here, we have been outside Ottawa up to 2 to 3 hours drive. Little bit more complex for the team, but we can do that now. In terms of result, some of the slides that I will show you have not been published, so I gave you the primer of the result. The population age is around 75, with 21% more than 80 years. Interestingly, 2/3 of the patient participant were women. Only 4% did not have a registered PCP, but as you may know, having a registered PCP and having access to a PCP is sometimes different. And what was very interesting is that in terms of epidemiology, the prevalence of cardiovascular risk factor, non-cardiovascular risk factors in the population was very high. 2/3 of the population had at least one cardiovascular risk factor. So that's the result of the abstract, graphical abstract of the paper we submit for the result of valvular heart disease. So we screen, at that time we screened a little bit less than 3,000 participants with POCUS. The rate of valvular heart disease detected or suspected by POCUS was around 5%, and it was confirmed significant by transthoracic echo in 75% of the population, meaning that the prevalence was around 3.8%. And in the following 6 months, 7% of these patients that were detected with valvular heart disease were referred for an intervention. In terms of non-echocardiographic abnormalities, so patient referred to emerge or semi-urgent were quite rare. Non-urgent echo abnormalities was around 7%. Half of them approximately were enlargement of the ascending aorta. We used 40 millimeter at the beginning as a threshold, and now we are using 45 because we were finding too many patients with enlarged aorta. And risk factors, I will show you the result here. So the series are slightly different because we did some analysis at different timing. But in the first 1,200 participants, when we look at management of cardiovascular risk factors, we find that 25% of the population had uncontrolled and untreated risk factors. High cholesterol was a majority, high blood pressure as well, and still 12% had glucose intolerance or diabetes that were not known before. And we look at what happened as well as this participant. And it's interesting. So patients were referred back to family physician. You can see in green patient that had change in management is that many patients, when they were diagnosed with some abnormality, even if, for example, here statin was indicated, 2/3 or 75% of the patient did not have the statin initiated, meaning that there is a gap between screening and management. Some issues, some challenges. Targeting underserved and rural population is not easy. Advertisement, you need to advertise that you go in each locations. Logistical aspect we discussed, you need sonographers, you need nurses, you need transportation, especially complex in winter. When we find something, we should not neglect negative impact that it can have on participant in terms of stress. I highlighted the fact that we are now asking the family physician to follow risk factors and non-valve echo findings, but we are trying to implement a process with a nurse practitioner who can work in coordination with the family physician to take over that. And we are currently doing the cost effectiveness assessment. The cost effectiveness for risk factors is almost done. I should have the result in 1 or 2 weeks. And the cost effectiveness of valvular heart disease is the next step. So if I summarize what we have done so far, we are now at 5,000 participants that have been screened. We have been in 100 different locations. Our rate of valvular heart disease is significant valvular heart disease around 5%. Rate of non-valvular echo abnormality, again, ascending aorta, LV dysfunction, regional motion abnormality is around 7%. And 25% of the population had newly diagnosed uncontrolled cardiovascular risk factors. And some pictures of the team. You cannot do that kind of program without an amazing team of nurses and sonographers. The program was funded initially by research grant, and now it's funded by the Heart Institute. Next step, I'm happy to announce that we have the funding for our transportation vehicle. So we are planning to have it running in May 2027 and have the capability to go in any places to screen for cardiovascular risk factors and valvular heart disease and non-valve echo findings. I forgot to mention that since we have started the program, we have added now since a year screening for AFib, and we do with a cardiac device a screening for atrial fibrillation for all the participants. I stop here and be happy to answer any question you may have.